Dr. Victor Ugo, who's the founder of Nigeria's and one of Africa's largest user-led youth mental health network, Mentally Aware Nigeria Initiative, MANI for short. And you've got more than 1,500 active volunteers in 15 of Nigeria's 36 states. So you tell us what's important from your perspective. You can either choose to remain sitting or stand, as you like.
I'll sit. So I wear a number of different hats. Apart from being the founder of MANI, I also work as the senior campaign officer with United for Global Mental Health, which runs the Speak Your Mind campaign. So I'm going to offer perspectives from the different parts that I work with. With MANI, I'm going to go straight to the point. We did 3 different things. The first thing that we did, because we had to be intentional about how we mobilize the resources and both human and financial resources, was that we tried to enlist celebrities and influencers. So we did a campaign in 2018 called the 365 Personalities of Hope. What that meant was that every day throughout 2018, we had a celebrity or an influencer give us a quote about mental health. What that did was to bring them into the discussion. So when we reach out to them, we'll ask, do you think you can give us a quote about mental health? And when they say yes, we introduce ourselves as MANI and tell them the importance of what they are doing. So when they give us a quote, they post it to their many followers who get to know more about the organization and who are much likely going to be young people as well. So we use them to reach a large number of young people who accessed our platforms and started to reach out that they wanted to be part of what we are doing. The next thing that we did was to upskill them. So we have these amazing young people coming in and reaching out to us, and we had to create a group. So we have an orientation group where they get to learn about mental health, they get to learn about mental health leadership, they get to learn about all these things that they should say about mental health, like common languages that we should use, that we need to start using, and unlearn discriminatory languages as well. And we also, more importantly, taught them how to speak the language of policymakers. Because in Nigeria, we don't usually have young people engaging directly with policymakers. And we thought it was important to teach them how to engage directly with policymakers, what they should say and how they should say it. So we have these groups, we have this monthly conversation events that we call Conversation Cafe. So what the Conversation Cafe is that we have these young people in the beach, in the park, in a lush, fancy restaurant, and they get together and sit down and talk about just an hour and just talk about mental health, talk about very unusual discussions like schizophrenia, talk about the mental health bill, things like that. So what that has done is that when they come with little knowledge or knowledge of what we are going to be discussing, but when they leave, they're already tweeting about what they have learned and how they intend to take the knowledge forward. So that's one of the things that we do. But another thing else that we do is that when we go to schools to speak to students, we don't just teach them how to reach help or how to seek help. We also teach them the gaps that exist in policies in very simple ways as well, and in languages that they understand. So this was the second thing that we did. And the next thing that we did was that we had to start building resources that can help them frame narratives. So one thing that's very important in getting the attention of policymakers is how you frame what you're presenting. In Nigeria, if you don't sensationalize a topic, there's a chance that policymakers will not notice it. There was a video that was released 2 months ago on sexual abuse in universities. And with that video just being out and circulated almost in various settings, there's a new law now, actually, that has been passed on criminalizing sexual abuse in universities. So if you don't sensationalize whatever option or whatever thing you want to speak on, you will not get the attention of the policymakers, at least to the extent that you want it. Now, to my next hat, I work at United for Global Mental Health. Apart from the fact that we've been advocating on the global level for increased funding and increased attention for mental health in different settings, one key example I can give is our work with the Global Fund. So with the Global Fund, we have been able to include mental health in the discussion. For example, at the Replenishment conference last month or 2 months ago. So for those that don't know, the Global Fund is a group of funders or a coalition of funders that fund programs related to TB, HIV, and malaria. So we saw the importance of including mental health in this discussion because, across the world, there's growing acknowledgement that the global targets for HIV and TB would not be met if you don't include mental health in discussion. So we were able to get mental health into that conversation. Last week or last 2 weeks, we just celebrated in the office having mental health as a panel session in the board meeting of the Global Fund, which is a big deal. Now, apart from having the discussion, so it goes both ways. You can have discussion at global level to assess funds that have been raised for anything related to mental health. But if you don't have countries demanding for that fund or not knowing how to assess it, that's a problem. And that's where the Speak Your Mind campaign comes in. So apart from being a globally united, nationally led campaign, the Speak Your Mind campaign connects and empowers our campaigners within the countries where we're working, so we work in 15 countries, to advocate for funding and know when the funding becomes available and how to seek it. So it's not just for the organizations that work in those settings, they also alert the governments or the ministries of health to know when such funding becomes available and how to assess it. And and one other thing else that we do is that we try to help these campaigners assess funding that is necessary for them. So it's 1 minute remaining. It's imperative that we understand that organizations that work in low-income settings don't have the resources to work with. And there's so much conversation today about all the amazing things we want to do, but the real question is who is funding them? Who funds all of these interventions? So that's one of the questions that we're answering at United. So we provide, or we connect these local organizations to funding. We try to get them beyond the roadblocks of income limits and country priorities and make sure that they submit appropriate proposals that can give them access to funding. I've been successful in that sense. Thank you.
Thank you very much indeed, Victor, for that very important perspective there and sharing some of your concerns with us. Thank you. Camilla Knox-Peebles, you're Chief Executive of Amref Health Africa UK, and I know you're very, very passionate and enthusiastic about what Amref can do in removing barriers to mental health care and support in Africa. So perhaps if you'd be so kind as to give us your comments.
Yeah, thank you. Thank you very much. For those of you who don't know what Amref is or who it is, Amref has been working on improving health and healthcare in Africa for over 60 years and has a specific focus on women and girls' health. We work in partnership with governments, the private sector, and other public sector organizations. Now, our work on mental health covers 3 key areas, which I'll go through. One is ensuring that our programs are holistic and address stigma around physical conditions and mental health. 2 is work on advocacy and lobbying as part of Universal Health Coverage 2030. And 3 is around innovation and particularly targeted at youth. So starting with our programs, I just wanted to give you a few examples of how we have integrated mental health in our broader program. The first example I wanted to share with you is the work we've been doing with children between 7 and 17 years old who are disadvantaged and live in the informal settlement of Dagoretti in Nairobi. Many of these children are either drug users themselves or from families who are drug users or who have violence or have been violent with each other, with the children. Many of these children suffer from addiction, depression, low self-esteem, and a number self-harm. The children attend a center run by Amref and attend a year-long course that includes remedial school, art, sports, and counseling, 10 sessions per child per month. And I was lucky to visit it last month. The center has accompanied around 26,000 children in the last 19 years and has an 80% success rate, whereby 80% of the children either then go back to school after doing the course or go into work. Now, the evidence shows that the reason the success rate is so good is because, largely due to the holistic approach that we've been taking, both to address the physical needs of the children, but also their mental health needs. And then following them up and with them as they go back to into their communities. The other example I wanted to share is on addressing obstetric fistula and the stigma around that in Uganda and Tanzania. Many of you will know that obstetric fistula is incredibly painful, but it's also highly stigmatized in Africa. And women sufferers were found to be very isolated and have very low morale and self-esteem, and in most cases their husband had left them. Amref provides them with a comprehensive package of care which includes not only reparative surgery but also psychosocial support. So they receive individual counseling and are assigned to small support groups. They then become ambassadors within their own communities and trying to identify and encourage women who are suffering from fistula to actually come forward. And in that way, they're actually also working very importantly with husbands and men in the community. And just a small success is for us that the women that we've been working, the women that have come forward, are still with their husbands. Grace spoke this morning about the importance of youth and of working with youth and their families and in discussing mental health issues. And I just wanted to share a story from one of our champions on ending female genital mutilation. She was telling me about how they've created these safe spaces for mothers and children and daughters to discuss issues around harmful cultural practices, stigma, and mental health. And she's from Marsabit in Kenya, and she's called Diram Duba. And one of the things she was saying was just so extraordinary and new, was the fact that the mothers were having these, I just assumed they would have these conversations. It turns out there were many conversations that were never had. But coming out of the home into that safe space has allowed them to have conversations that they would not have had before. So again, very powerful moment for women, them as mothers, daughters, sharing and anticipating some of the issues as they grow up and potential mental health issues. So our work is very much on mental health around supporting individuals together with families and the broader community. The second piece, and we've alluded to it this morning as well, but I think it's a key policy moment, and that is the Universal Health Coverage 2030. AMREF co-chairs the steering committee on UHC 2030, and as you know, world leaders actually endorsed the policy agenda in September just now at the UN General Assembly. And we think that's a real moment to actually peg mental health on it. It is there, it is central in the demands of UHC 2030, and I just wanted to remind us of that because it hasn't come up that much. But it does say that every human being has a right to the enjoyment of the highest attainable standard of physical and mental health without distinction of any kind, and that primary health care is the most inclusive, effective, and efficient approach to enhance people's physical and mental health. AMREF is going to be lobbying on the back of that, supporting youth to hold their governments to account, to implement the asks of UHC 2030. And we've had some success around health and investment in health in the past. So we're hoping, and again, stressing not only the physical but the mental, to have more and make more progress with governments through that advocacy. And the third point, I've run out of time, is innovation, and you have heard a lot about innovation, so I'll stop.
Thank you very much indeed, Camilla. Thank you very much indeed, Camilla. Our next speaker is Krik Lund, who's Professor of Global Mental Health and Development at Cape Town University and also the Centre for Global Mental Health at King's College here in London. And Professor Lund, your research has taken you across various sectors of mental health policy. You've also looked at the links between poverty and mental health, particularly in low and middle income countries. But perhaps to give us your priorities in this field that we're talking about now.
Great, thank you so much. So I've been asked to talk about how do we mobilize human and financial resources for mental health in low and middle income countries. And I'd like to draw your attention to what I think are three challenges, and then 6 opportunities or ways in which these challenges could be overcome. And I think it's really important to bear in mind we have many challenges, but I think we have at least double the opportunities. So the first challenge, I think people have already spoken about this today, is our historical legacy in African countries when it comes to mental health. The vast majority of the resources that ministries of health allocate to mental health are located in psychiatric hospitals, and most ministries of health spend less than 1% of the health budget on mental health. We have an expenditure of around 10 US cents per capita on mental health in the African region, and we have around 9 mental health workers per million people. So these are huge challenges. Secondly, stigma and ignorance continue to inform the attitudes and the behaviors of policymakers. Stigma and ignorance about the causes of mental illness and also about the options for treatment. And thirdly, I think there are huge gaps in our capacity to plan and deliver in many ministries of health in African countries. We've seen a very exciting shift, and I think Florence has spoken about this morning. In 2001, when the first Mental Health Atlas was conducted, just under 50% of African countries had a mental health policy. Fast forward to 2017, more than 72% of African countries now have a mental health policy. But it's the conversion of that policy into actual resource allocations, into delivery of services on the ground, that remains the main challenge. And I think there's also an opportunity there, which is, can we build the capacity of planners, district and provincial, state-level health planners to plan and deliver mental health services better? So on to the opportunities. And I want to share with you some of our experiences from the PRIME consortium. Just to do a bit of advertising, this little flyer is in your pack. PRIME was a DFID-funded research program consortium, which we ran from 2011 till 2019. We just wrapped up in April this year. And it's been an incredibly exciting journey. We've been working in 5 low and middle income countries, which are Ethiopia, India, Nepal, South Africa, and Uganda. And the focus of our work has been on how do we integrate mental health into primary healthcare systems, routine, low-resource primary care systems. So I want to draw 6 main lessons from this. The first is about partnership. It's really important, if we are going to put new investment, new resources into mental health in Africa, that we do so in collaborations between researchers, policymakers, NGOs, and the WHO. And this is really what we tried to do in PRIME. DFID gave us some seed funding before we got the grant to hold a meeting to develop our proposal. And so we invited our Ministry of Health partners to that meeting. We asked them, what are your priorities? What should we be researching? And that completely shifted the tone of the conversation, and we were very much able to align what we wanted to do with the priorities of the policymakers. The second lesson from PRIME is to start small. We started with 1 district demonstration site in each country. And we went through a process of running theory of change workshops and collaboratively getting all the stakeholders in the district to develop a district mental health care plan. So it wasn't just about training primary care nurses. It was much more about developing a sustainable plan which was budgeted and integrated into the health budget for that particular district. And it included capacity building at the district health management level, at the facility level, and then also, very importantly, at the community level. And so from that process, we've been able to take that model and scale it up to other districts in most of the countries that we've been working with in PRIME. The third lesson from this is that it's vital that we strengthen health systems. Many health systems in our countries are really struggling with the existing burden of other health priorities or other health conditions. And so if we are going to introduce mental health, we need to also introduce things like continuous quality improvement, support for primary care providers, enabling them to build their own capacity and get support for the work that they do. Fourth lesson, it's really important that we do very rigorous research, high quality scientific research about what works and what doesn't work. One of the other things we've done is we ran a randomized control trial as part of the AFFIRM collaboration, testing task sharing intervention using community health workers to provide counseling for antenatal depression in Khayelitsha in South Africa. And we found a non-significant result. Our intervention effectively did not work. And there's a huge amount that we can learn from that about the importance of really adequately training, sustaining, providing ongoing supervision and support. So learning from what works as much as what doesn't. And in relation to PRIME, we've had a lot more success. We've had really demonstrable impacts on individual outcomes. We had cohorts of over 3,000 people that we followed across the 5 countries for over a year, showing significant improvements in clinical and functioning outcomes. And this is services delivered by non-specialist health providers. It's very, very exciting. My fifth point is the importance of using policy windows. And I think the previous speakers already spoken to the really vital importance of the SDGs, universal health coverage, and the opportunity now to get mental health in there. As countries move towards universal health coverage, we should be making sure that mental health is included in core packages of services. And then finally, it's vital that we link mental health to other development targets. Mental health isn't only a health issue. It's also an issue about poverty. It's an issue about gender-based violence. It's an issue about education. And I just wanted to mention in closing a new project which we've got underway, being led by Sarah Evans-Latsko at the London School of Economics, called Chances 6, We're looking at existing longitudinal data sets in 6 low and middle income countries, 3 from Latin America and 3 from sub-Saharan Africa, and the effects of cash transfer programs on the mental health of young people. So it's possible to start thinking about how do we address social determinants and show their impacts on mental health. And I think this is really where we should be going more, not just thinking about health sector, but thinking in a very broad way. So thank you very much indeed.
Thank you very much indeed for it. Thank you, Professor Lund, for setting those out so clearly for us. So Dr. Titi Banjoko has been is a healthcare professional by background, which she works as a managing director in the National Health Service. And Titi has been a really passionate and very active advocate for capacity building and also giving a lot of advice in this capacity building in Africa. And I'm very happy to say she's on the Council of the Royal African Society, a very valued member of the trustees there. So, Titi.
Thank you very much, Chair. So I've been asked to speak about mobilizing the diaspora, both from a human and financial perspective. So what I'm going to do is just set some context, talk the levels in which the diaspora are engaging and give examples and finish with recommendation. I think the first thing I want to say is that people tend to see the diaspora in isolation. And why I say in isolation is I'm a member of the diaspora. I work at a very high level within the NHS, but I live a double life. So I could be here, I'm here, Raz, but actually I do have influence within the NHS. Depends on how I'm approached. And that actually goes even for the chair. She's a member of the diaspora, if you know her biography. But what I'm trying to get at is, in context, there are diaspora at every level, globally, in very strategic positions, regionally, strategic positions, nationally, locally, in both public, private, and NGO sector. And when they're seen in isolation, they're not able to bring their, what I will call as their valuable assets to play and, to utilize in the continent. Because if you are approached in a singular way, then you tend to adopt that hat. And I'll run through an example. So the diaspora can influence policy and regulation. That influences quality. But you also have diaspora in places where, within the UN setting, within numerous settings where policy actually is being set. Are they being influenced to be able to actually understand, as I said, that this is a time where you can put on your diaspora hat and actually use that for good? Funding. Funding is important. There are a lot of diaspora that actually do already own multi-million-dollar businesses. How are they engaged in this agenda? And how do you approach them in this agenda? And that actually, to me, is becoming increasingly so. I tend to look at the African diaspora and I look at the Indian diaspora and I say to myself, there are a number of parallels here. If you look at many of the Fortune 500 companies, you will see an Indian at the top. They actually are very engaged in their continent because they are approached by their Indian government and seen as a valuable asset. They're not seen as somebody who is a disruptor, but they're actually seen as an influencer, and you can see that actually running through medical healthcare in India. Many of us from Africa know that India is the place most people go to. And when you look behind the scenes, even from here, Indians leave from here to go to India now to go and work. There is a reason that is happening. So mine is, policymakers tend to sometimes see the diaspora as a nuisance. Well, then they keep their money. There are diaspora people who own fortunes and can actually influence and support and funding depending on how you approach and engage with them. So that's another level. Service delivery is an area that, generally speaking, people tend to engage the diaspora because of the skills, ignoring what I've said earlier on about the context, about money, about how you can utilize them. So they're approached in terms of, they're healthcare professionals. We all know the same, and therefore we need their skills. But actually, it's beyond just that. It's not just the healthcare professionals. Mental health, there are a lot of people operating in the mental health space that are not medical healthcare professionals. They're social workers, they're therapists, they're counselors. They're people actually who are able to offer what I would call lower value treatment in terms of cost, but high impact. Are they being mobilized? Advocacy. Advocacy is very, very important, especially when you have diaspora people who you see as, there'll be a list of 100 influencing diaspora, top black, you know, you see it in key magazines. Actually, building on what you said, there can actually be people that could be coming out and advocating for mental health. But do we mobilize them? No, we don't. And I'll just finish off with examples of where some of the good things are happening. So I'm a trustee at THET as an example, and THET for a long time has been funding a number of partnerships where they train people. Uganda is one country where they've done a lot. There is a very vibrant Ugandan diaspora, and there's a partnership between Northeast London Mental Health Hospital and a hospital in Uganda, and that's sustainable, and that's been going on. The Ugandan diaspora are very engaged in that. Forward is also a diaspora-led organization, and they deal with gender-based violence here and in the continent. And actually that is focused on youth, but also bringing in the intergenerational conversation, because there are a lot of mental health issues that sometimes is to do with intergeneration, especially the elder generation living here and the children they have brought up here, where there's a clash of cultures or clash of understanding, and they operate in that space. Another powerful asset in the diaspora I describe to people is the religious community. Like it or not, they're very powerful. They're very, very influential. I said in the group where I was, I know in the UK, when somebody wants to run for mayor, whether they believe or not, they know how to go to the Hindu temple, they know how to go to the church, they know how to go to the mosque, they'll wear everything, they'll take off their shoes, they'll do whatever it takes, even if they don't believe, because they understand the power this community has to influence and shape the agenda. Well, when it comes to mental health, I would hope that we also engage this community. It's not us versus them, it's us with them. And recently I went to I'm not going to name a place, but I went to a mental health event being hosted by one of these religious communities. It was packed. And the audience was captivated. And I thought, well, we can't influence as they can. And almost immediately I could see the sort of penny dropping with some people. And for me it was, why don't healthcare professionals and people engage with this community? Why is it the politicians know how to do it, but we don't? So that's one thing. So my final recommendation, obviously, is we've heard a lot today. There is a lot happening in the space. But as we tend to do, it's all micro. I'm going to be honest. It's at this micro level. It's not scaled up. It's not coordinated. Some will clash with each other. It's almost as if we're competing. Sometimes you see some people competing for resources. That's not the way to work. It's how we come together in a coordinated manner and align, coordinate, and build on to develop sustainable partnerships, noting that there's not an unlimited pot of resources, but how do we do that? And for me, that actually will progress the agenda beyond that which we can imagine.
Very interesting. Thank you, Titi. I wonder, Titi, you've raised a very interesting question. I mean, who do you think could take the lead on that? Is it somebody like Florence, who leads on mental health in Africa, based in Brazza? Is it the WHO headquarters in Geneva? Is it like the people here, you think? Really, community and health professionals and...
I think it has to be something neutral that doesn't smell of I'm going to be honest, of a government. And the reason why I say that is I do believe that we need to mobilize. That philanthropy is a growing industry within the continent, and they have to be able to believe that it's neutral, where, when people are putting into it, it's neutral. So when you mention the Global Fund for
mental health,
it's neutral. It's seen as a neutral, and private and public and multilaterals given to that.
But that's the WHO special initiative, isn't there, for mental health over the next 5 years, Florence, and it aims to raise, $60 million over 5 years. It doesn't sound like a lot of money, given we've heard about the deficits in finance and also in resources and human power. Is it ambitious enough? And even if it were, where is that money going to come from? Have you any idea?
that's a good question, because it may seem like it's not a lot of money, but raising it hasn't been easy. So right now, only 6 countries have been identified, 1 per region. So that's already a problem. And we don't want to raise a bag of money for mental health, because countries then will expect there will always be a bag of money where they put the mental health activities. We want them to be planning for mental health within their government budgets. When governments go to seek a loan at the World Bank or African Development Bank or Islamic Bank, they should include mental health within the package they have prioritized. So we don't want that we are going to have a package for mental health that is not considered like any other condition.
Do you think that's the right approach, panel? Crick?
Yeah, I think it's a both and, I think we should be, encouraging governments to think in a sustainable way. But if we can get the money, I think we should take it,
But, I mean, does anybody know whether the research shows that as countries improve their health coverage, and perhaps, I mean, universal health coverage is very, very ambitious, do you immediately see a rise, a coincidental rise in mental health provision, or is it something that is still banished to the outer regions?
I think, the WHO Atlas shows a very clear association between national GDP and allocation of funding to mental health. So as there's more money available in the resource envelope, so the spending on mental health does increase. So there is that evidence.
So
also,
that would suggest raising awareness then is not as much of an obstacle as one would think.
No, and I think it's also important to show the return on investment. So Dan Chisholm did some very nice work showing that for every $1 invested in treatment for depression and anxiety, there's a $3 to $5 return on investment in terms of labor market changes over the period of the Sustainable Development Goals up to 2030. So there is that evidence on return on investment.
You, Crick, and also Dr. Titi made, the point, and I'm sure it's been discussed earlier, about the need to involve the community and, non-health sector in this. Anybody want to give an idea of just how difficult or easy that is? Do you have to actually, in the first place, convince these religious groups or traditional groups or whatever to demolish certain prejudices, or are they on the whole quite willing to cooperate?
My experience is they are willing to cooperate, because people tend to forget that they also are, some of them are users of service, only they're doing it it's hidden. In other words, I am aware of some religious leaders where they have their children have either committed suicide or things have happened to them personally. And actually, it is really helping, it's the support we provide them that gives them that safe space to then be able to come out and then advocate for it. And that's the key thing. I mean, I'm going to sound controversial here. I did, the other day, somebody was talking about Kanye West, and everybody knows about his mental health issues. And I said, actually, it's good he's come out, because it's good for men, black men, to understand that having mental health challenges is not to be stigmatized. But you need people to come out. And the person I knew of, his son had committed suicide, but he didn't want to say anything because, of course, first of all, his congregation might disappear, because he obviously must have a demon. Otherwise, why would his son have committed suicide? But it was the support that was put around him, and that's why he hosted that event. Because, and you'll be surprised that the more people, a lot of people attended, and then people started saying their experiences. And I'm not alone is really, I think for me, is what unblocks everything. When people speak, and speak visibly, then people stand out. If you don't speak, then you feel you're alone. The documentary you were referring to about sexual harassment in universities, it's been going on for years in Nigeria. I'm sure it's in other African countries, but it's been going on for years. It was going on when I was there, but nobody spoke out, so you kept it quiet. That documentary gave the boldness for a lot of people to come out and speak through their experience, and it created so I think it is creating that safe space, and that onus is on all of us, to create that safe space and support people when they do come out, rather than be the one to tell them to keep quiet.
But of those students you mentioned, yes, in your presentation, Victor, I mean, that's one thing. But the sexual abuse of particularly young women or girls who have special needs is something which we know goes on, and there's very, very little done about that, and they are often abused by members of their own extended family. And, you know, these issues, I don't know if this was raised earlier on, but this is something that isn't discussed, is it, very much?
I think it is starting to be discussed.
Is it?
With more awareness on the topic. More and more people are coming out to talk about the effect of that on them. I mean, people that have experienced this in the past come out to say.
So girls with special needs, for instance, who may be more easily exploited and maybe manipulated more easily. I mean, it's very, you know, the students were articulate young women who could assert themselves and say their arguments. But these girls who are exploited in this way, it seems to me that it's something that isn't really
It's
very...
not giving much attention.
No.
But let's say if the attention on mental health increases itself in the country, then those conversations will come up organically. That's my thought on it.
Okay, let's go to the floor, because it seems to me, you know, it's just making sure that people who have mental issues of whatever manifestation, whether they're permanent, whether it's because of poverty, or whether it's circumstances, or whether because they are special needs and so on, that they are valued as full human beings. And it seems that actually often it's the case that they are not valued as full human beings. And we've heard about, you know, the tragedies. I think there was a fire, wasn't there, in South Africa a couple of years ago, when people escaped by and large, except those who were in the, who, you know, mental faculties were not quite there. It's very, very tragic. And the Nigerian situation we've just had recently. Who would like to say something from the floor? Yes, one here. I'll also go to the back. Let's start with you. Keep your comments brief. Introduce yourself, if relevant, please. And it's quite a small room, so if you bellow, we might hear. Yeah, briefly. It can be a comment.
Eugene Kinyande, psychiatrist from Uganda. I head the mental health unit. I would like to say that, I mean, we've just completed a study in Uganda where we followed up 1,200 patients with severe mental illness. We've documented very high rates of physical and sexual abuse. 50% sexual abuse, physical abuse, about 30% sexual abuse. Yeah, the research is coming out. I'm engaging the ministry. I'm seeing resistance from the managers of the hospitals. Yeah.
Very, very sad, and that's a terrible statistic to give us, 50% and 30% sexual
Some of them by
abuse.
health workers.
Sorry?
Some of it by health workers.
Yeah, I mean, it's really just absolutely appalling to hear that. Thank you. And then this is raising awareness about this is so important. Just give the microphone there, please, Shayla. I'll work very quickly, but that's admirable in terms of duration. Thank you.
Yeah. My comment is actually on the diaspora, but just to comment that even people who don't have disabilities have high rates of sexual abuse, as high as 50%. So studies have shown that there are very, very, very high rates of sexual abuse, even in normal populations. I think it's something that we don't talk about on the African continent. So it's there. Right. I just wanted to mention that very powerful talk. And I'm one person who believes very much in the diaspora in great use and a purpose for the diaspora being there. There's a reason that why you were there. And I want to mention that the Center for Child and Adolescent Mental Health, the last 9 years, we've trained well over 110 child and adolescent mental health professionals in 14 African countries, was basically because we linked up with the diaspora. We didn't have the capacity to start off. I was a lone ranger. But then we linked up with people in the diaspora on the onset who were coming out. Some of them were coming on the ground, some are coming with their own resources. And they laid a foundation for that. And that is why today we have a strong army of child and adolescent mental health professionals, because of the diaspora.
Thank you very much.
And
Professor.
I think it's something that the African continent needs to build. I mean, I just wrote an article in my alumni, I went to University of Ibadan, alumni, that the diaspora is what is going to really help us to build. So we need to have, and they will come in different ways.
Sure.
Different ways. Thank you.
Thank you so much. If we could just make sure that people at the back, I'll come back to it at the end, just give the microphones to the back there. How many other hands?
although I work for...
Just introduce yourself. Yeah.
Sorry, my name's Bex Gordon. I work at AmRef Health Africa. However, what I'm going to say is a completely personal experience. I hope that's okay.
Sure.
I have a severe... I just really interesting that you're talking about, for content warnings, like sexual abuse and disability. I have a disabled sister, and we were recently told from her NHS doctor that we should take her and change her anti-epileptic medication, because the current medication she's on makes her... There's a possibility of her getting pregnant. Now, the idea of my severely disabled sister being sexually active is completely incomprehensible for my family and I. So my mum questioned why that was brought up to our attention. And our doctor said, well, because if she in future ever moves into a home, the chances of her getting abused are extremely high.
Lord.
And that happened last week, and is a big talking point in my family and I in the NHS. I don't really have anything else to say. I just wanted to say that as a comment.
Yeah, that's...
and
the fact that it just seems to be accepted and just said
the fact
as
that
a
it was
matter
accepted,
of fact.
Thank you.
And that's here in the UK as well. So thank you for that personal story. Yes, this lady here, yeah.
Thank you.
And then there are two more here, and there's one here. If you could stand, it would help. Just introduce yourself briefly. Thank you. There's a hand there. Yeah.
Thank you. My name's Diane Kingston, and I work with Sight Savers. I wanted to just pick up on something that you said towards the end of your presentation, Zaina, was that every human life should be valued. And I'm absolutely flabbergasted that we've gone through almost all of the day here today without mentioning the United Nations Convention on the Rights of Persons with Disabilities. You've talked about the Sustainable Development Goals, you've talked about universal health coverage, there was even mention of the Child Rights Convention at one point, but almost absent completely was the rights of persons with disabilities that deals not just with the rights of people with physical impairments, but also people with mental health conditions and psychosocial disabilities. And just coming back to the point that the lady made down here, we know that women are more at risk of sexual violence than men, but women and girls with disabilities and those with psychosocial disabilities, and in particular intellectual disabilities, I think you were alluding to, are at far more at risk of sexual violence. And the Convention on the Rights of Persons with Disability upholds those rights for all people. The UK has ratified the convention. It's been examined once. It's due for examination again. Many African countries have also ratified that convention, and it can be used as a tool by individuals, by organisations at a grassroots level to hold your governments to account, and I urge you to do so.
Thank you so much indeed. A very important lacuna to have raised. Gentleman at the back, and then there's one here, and one here. Yeah, if you introduce yourself.
Yeah, my name is Dr. Sondineru.
Oh, just hold the microphone closer.
Yeah, my name is Dr. Sondineru. I'm a consultant in NHS. I introduced myself in the morning. This goes particularly to Nigeria, whereby you said, one of your colleagues said that there's a law now against sexual harassment in the university. I think that's not enough, but other target population is workplace, and that should be included. It's not every sexual encounters in workplace that is consenting. I mean, there are problems in that area as well. I think the females who are in the higher positions, both in the university or in other organizations, should take a lead in fighting against that. I don't know what you feel about that.
Thank you very much. And there was one here, and one here. Yes, the microphone here. If you keep it to like 30 seconds, I can go to you four very quickly. Yes? Just distribute the microphone.
Okay.
There's one here as well, Shayla.
My name is Veronica. I'm a sociologist by training, and I'm currently doing the MSc in Global Mental Health at King's College London and London School of Hygiene and Tropical Medicine. I wanted to bring about, when it comes to mobilizing human and financial resources, particularly in an African context, particularly in mental health development, this role of the international community. We talked earlier in one of our work streams on evidence and research on decolonizing hierarchies of evidence and creating bidirectional relationships between global North and South collaboration. But as someone who is from the diaspora, but not from an African diaspora, as someone who's lived and worked in South Africa, I always feel so conflicted when I go and start thinking about doing work in an African context. I don't feel that I should take up too much space. I feel that I should be more so an ally than someone that owns the research that I want to do. Okay. And so this is a real genuine question to the panelists and to those of us who have a vested research interest in Africa, who are not Africans themselves. How do we ally ourselves with and by and for our African colleagues?
Thank you. That's
my
very
question.
Thank you. So lady here, and then the final point there. Just keep it brief if you'd be so kind. Yes.
Okay. Hi, my name is Elisa Hamilton, and I just finished the MSc and came into it as an art therapist in Senegal. And my question is about rigorous research and using economic evaluations to influence policymakers and decision makers. In Africa, a lot of the tools we have to do this are lacking. The quality of life measures haven't been validated in a country, or value sets to calculate DALYs don't exist for that country. And so I'm wondering how we prioritize this when you can get a lot more money a lot faster with a compelling documentary or a champion.
Right, yes, well, that's true. And briefly, if you'd be so kind. Yes,
Hi,
thank you.
Susan. I just wanted to say that I just think we need to recognise how common sexual abuse is. And it's not just in Africa, it's in England. I mean, how many of us haven't been sexually abused? I mean, I've got a friend who was sexually abused by her father from that side. And it's very, and it took her until she was sort of 30 or 40 to actually admit to it. I mean, you know, we just take it for granted, we just accept it.
Yes, it's a very difficult thing to talk about. If she didn't talk about it for 30 years, as you say here in the UK, where there are many mechanisms whereby you can talk about it. Yeah, it doesn't just go on in Africa, it's just because we're discussing mental health in Africa that we brought it up.
As well.
Yes, yes. So I think it's just one of the barriers. Okay, very quickly, panel, unless you're really burning to say something, I'll leave it with the audience. Yeah, okay.
Thank you very
Briefly,
much. My name is Philip. I work with CBM in Nigeria. So my question is directed at the speaker who talked about, speaker from, AMREF, yeah. So we're developing a women's health project in Nigeria, and the case is actually big. Not less than 150,000 women and girls suffer this. That's based on statistics, and every year 13,000 more add. So there are serious or harmful traditional practices that fuel this within the country, and most of the cultures or people don't seem to want to do away with those practices. When you spoke, you mentioned something about supporting these women to become ambassadors. So I don't know if AMREF has a program dedicated for this, because this is where we need to leverage support and send these young women that we're also supporting.
Very important.
Thank you very much.
The harmful traditional practice. Perhaps I could suggest that you take that up as a bilateral in the networking session, if that's all right. Yeah, you'll identify each other. There's a chap there. Oh, God, all right. I've been told like 20 seconds.
Yeah. I just wanted to answer the question about how to work in Africa, because it's a question that comes
very
up.
quickly then.
With humility, recognizing your limitations, your strengths. You're needed, but you're needed in a way that recognizes what you can actually do.
Thank you very much. And final point, was it there? I see these hands go up and I feel like, they ought to speak. Sorry. I've said to the panel, you've had your 5 minutes, so just very quickly there and there. Yeah, last two. Yes, there, and the lady in the spectacles. Yeah, briefly. Just say who you are quickly. I'm sure you all know one another, but still.
Good afternoon.
Hold it closer.
Good afternoon. My name is Nyareso. I'm currently on the MSc program. And I just wanted to ask, as researchers, I'm just going to add on to what my colleague said.
Sure.
How do we not impose on culture when you're trying to alleviate psychological distress in a context where physical abuse is the norm, and you have people saying, it is my right to do this, to do that.
Okay, thank you. And the final point there, Professor Stanley, you're going to have a chance to speak, so perhaps you could incorporate that one in your... I see your pen is poised. Yeah, traditional things. Yes,
yeah,
final
hello,
point, thank you.
I'm Ursula Reid, I introduced myself before. My question was about language, because somebody mentioned about developing common terms, common language terms. And of course, Africa has a plethora of languages, even within nation states. So I wondered if anybody has been giving thought to how we talk about mental health in all these diversity of languages.
All right. I think Titi said, you know, to have a concerted thing. So maybe that's something we can take up. Panel, thank you very much indeed. Victor, Ugo, you're staying here because we're going to bring our last innovation presentation about Project Holuma, and you're going to tell us a little bit about that. But the rest of you are released from captivity. I'm going to stay.